really good work, and so I'm looking forward to just being on the team with them and working to serve Oregon's communities.
Okay. Thank you very much. Okay, committee, we're going to now we're going to hear another topic that's just as important. Oregon Health Authority behavioral health update.
Mr. Co-Chair, members of the subcommittee, while the agency is getting set up, just a reminder that the presentation material is posted on OLIS. And
Bless you. Go for it. Dr. Allen, good morning. Welcome.
Co-chairs, members of the committee, Patrick Allen, Director of the Oregon Health Authority. I'm joined today by Steve Allen, our Behavioral Health Director, to talk about behavioral health. We're not talking today about the behavioral health asks that we have in front of you this month. Rather, what we're trying to do is set some context for those asks. What we hope to do over the next bit is give you kind of a basic grounding in how behavioral health works in the state, some assessment of its current state, and then talk about our direction and vision for moving forward. And Steve and I will tag team that. Feel free, though, of course, as I know you will, to interrupt with any questions you have. What I was expecting. So we try to ground everything that we do in the triple aim, the notion that our mission as an agency, among other things, is to deliver better health, better care at lower costs, and behavioral health is a critical component of that. And what we try to do always comes back to that notion of those functions. I'm apparently lost.
PowerPoint, I think. I've seen that screen before. There you go.
But why is it doing that? That's what I did. That's what I did. Okay, we'll figure it out. So the first thing from a grounding standpoint is just to think about the term behavioral health. And I have been fond of saying when I came to OHA, I knew nothing about behavioral health, and over time I've gotten to where I know next to nothing. One of the things I have learned is the fact that that phrase gets used differently in different contexts and by different agencies. For us, behavioral health is the combination of mental health and substance use disorders treatment and recovery. In a school context, some of you know for fun in my spare time, I'm on my local school board. In a school context, behavioral health behavior means some mixture of mental health and behaviors and actions in a classroom. At DHS, it's got yet a little bit different context, and so it's easy, particularly in a committee like this, where you'll see various of those topics, to hear that phrase and maybe not realize that it's being used slightly differently. So again, for us, it means mental health and substance use issues. At a super broad level, when you think about how do we deliver behavioral health resources and services, on the left-hand side, you can see that as an agency, we kind of think about three very broad groupings, and these are by no means definitive or hard lines or anything like that. But when you sort of cluster the work, we think in terms of clustering it around substance use disorders, treatment, recovery, and then adult and children's mental health. And adult and children really have some significant differences in terms of the types of things that we need to do and try to do in the investments we make. And so that's again a very broad, general kind of a demarcation. On the right-hand side is sort of who do we work through to affect those three broad population categories. It includes coordinated care organizations, community mental health programs, and then lots and lots of other partners, ranging from individual service providers to nonprofit organizations and more. And I'm going to spend some time on CCOs and CMHPs in a little bit of detail. We spend a lot of money on behavioral health in the state, $3.2 billion. for the 1921 biennium, up from $2.2 billion in 13-15. And you can see the way that basically is grouped. Medicaid is the large blue portion of the bar. Much of that, though not all of it, is delivered through coordinated care organizations. The small blue bar is also Medicaid. It's the Children's Health Insurance Program, so you can think of those two really in the same category. There's non-Medicaid behavioral health spending. That is largely money that flows through community mental health programs, though not entirely. The kind of aqua-colored bar near the top is the state hospital. That's 100% general fund, and so it's very, very expensive healthcare that gets delivered. And then there's a small amount of pure prevention in this area. This is a little bit of a schematic that tries to show the funds flows. Don't pay attention to the size of the boxes. They were drawn more to be able to get the arrows to line up and not to reflect relative dollar amounts. But the idea is that we get federal money that flows to the state and to the Oregon Health Plan, either directly in fee-for-service services or through CCOs. And those come from a variety of sources. They come from multiple federal agencies, not just CMS for Medicaid, in the form of block grants, programmatic grants, as well as our regular Medicaid spending. That state money flows to CCOs and to other Medicaid providers. There's also private insurance in the system. The state money flows directly to the state hospital. That's general fund, as I mentioned earlier. We also provide money to counties, which in turn either directly deliver the services of community mental health programs or have identified some kind of a nonprofit organization to act as the CMHP in their area. And that purple box center providers, who you can see at the end of the day get a really complex web of different funding streams from different payers, each of whom have different objectives and different rules and structures for that payment. Another sort of broad generalization I would say about behavioral health is that the level of benefits that individuals have access to vary markedly with the nature of the payer. The Medicaid benefit is probably, I would argue, the best behavioral health benefit of the various providers. Private insurance is not as good, and private insurance in the form of self-insured plans is probably the worst of all of the benefits and the most difficult to access. So coordinated care organizations, just as a refresher, coordinated care organizations are the 15 different entities around the state who are formed to be basically a local delivery vehicle for the Oregon Health Plan. Structurally, there are all sorts of different kinds of flavors of coordinated care organizations, ranging from very small entities with 15,000 or so members that are community-based to entities that have their as their DNA medical practices. There's one CCO that's a wholly owned subsidiary of the local hospital system. Health Share in the Portland area is a complex organization that has various risk-accepting entities that are hospital systems and insurers, and then there are purely insurance-based CCOs. In any case, the 15 of them are designed to be able to approach healthcare, the triple aim from a local perspective, bringing together that payer with the providers and the community to figure out what are the priorities in that local community. About 85% of people on the Oregon Health Plan are members of CCOs and receive their care that way. CCO 1.0, as we were doing assessments of it before we moved into CCO 2.0, had some weaknesses around behavioral health, and we've tried to list some of them here. The basic idea is the system was complex, access to services was difficult, and in some instances there was sort of a delegation, almost kind of at an arm's length delegation of behavioral health to others, and so you had experiences where it was difficult to hold the CCO accountable to being able to deliver that benefit. compounded by the fact that the CCO 1.0 contracts were pretty challenging to administer. They were complex, not clear, not well enforced by the agency over time. And these are all things we've talked about before that we set about trying to address globally in CCO 2.0. In 2.0, around behavioral health specifically, first, behavioral health was one of the 4 pillars called out by the governor and by the Health Policy Board as the big drivers of what we needed to do to improve coordinated care. So we in contract and in policy cemented the notion that regardless of who they might contract to deliver services, the CCO itself is responsible and accountable for the behavioral health benefit, and we've tried to provide contract language that helps to help firm that up. We have new requirements around network adequacy for behavioral health, and we've also required that priority populations be eligible for intensive care coordination. You may remember a letter from Governor Kitzhaber that criticized sort of top-down regulatory dictating of standards. Well, this is exactly what we're talking about in that circumstance, is being much more direct and accountable in contract and in OARs to make sure that people who have behavioral health needs are able to get those needs met. And then we required something that was occurring in some places but not others, which was that behavioral health needed to be able to be delivered and reimbursed in a primary care setting. There are a number of ways to execute that, but the most common would be a primary care clinic hiring a licensed clinical social worker who is able to deliver services in that setting. And prior to CCO 2.0, some CCOs made that work pretty well, and some didn't allow it at all. And so that was another significant change. Community mental health programs exist in parallel to and ideally in close partnership with coordinated care organizations. You might sort of, in a lay sense, think of the county mental health program as kind of the mental picture of a CMHP, but it's actually a good bit more complex than that. There's a local mental health authority that identifies who will be the CMHP, the Community Mental Health Program. In many cases, that is county government, delivered directly by county employees. But in a number of cases around the state, that's some other organization that operates on contract for a community, so a nonprofit or other organization that delivers those services. The idea is that the CMHP, at a minimum, is the local safety net set of services for people with mental health needs. But in many cases, it goes far beyond that and becomes a frontline provider of behavioral health. Again, this varies extremely across the state from the CMHP being a kind of a one-stop shop for all behavioral health services. Klamath Basin Behavioral Health comes to mind in Klamath Falls. Other places, it's much more limited to the safety net services, and other providers do that work. There are 35 different entities around the state, not quite one per county. And you can see the breakdown of the different kinds of organizations that form those CMHPs. So with that as kind of a structural grounding, I'd like to turn it over to Steve Allen to talk a little bit about how the system works today. Yes.
Hansel.
Just more out of curiosity, which is the tribe that has the local mental health authority? Do you know?
Warm Springs. Is it Warm Springs? Warm Springs, yes.
Go ahead. Oh, did you have a question? Oh, sorry, Senator Byer.
Within the counties, it's in the service elements in the OHA contracts with counties, but how do they split out the substance abuse versus, I don't know how else to say it, the more other mental health issues from that one question. The second question is, what's the relationship between the mental health delivered through this stream and the CCOs? So
Co-Chair knows Senator Byer, back to that graphic I showed a little bit ago that was kind of the funding patchwork. Let's say we're dealing with a comprehensive CMHP that does sort of all services in a particular area. We as OHA will have a contract with that CMHP. That's a service element contract, it's called, that pays them to do certain things, mostly oriented toward mandated populations. The issue that we talked about a week or so ago, people who are civilly committed, those kinds of issues. They will also typically have an agreement or contract with their coordinated care organization to provide benefits that those members are entitled to under the Oregon Health Plan for services. Service element contract doesn't require enrollment in OHP or eligibility for OHP. Service by a CCO does, and so there's a little bit of their kind of overlapping circles if you think of the individual members. But that's part of the complexity of the system, is that notion that there are a couple of different funding streams for somewhat different populations. Through the work that we're doing right now to redesign the CMHP service element contract, and through the work we've done under CCO 2.0, we're trying to better align those systems so that they're pointed more in the same direction, but it's super complex.
I mean, how do you answer one of the concerns I've heard a lot about in various counties is that the counties take care of themselves first, and sort of the substance abuse providers get what's left. So I guess it's a question: how do you define adequacy?
Sure. Good morning, Co-Chair Nose, Co-Chair Byer, members. For the record, my name is Steve Allen, Behavioral Health Director for the Oregon Health Authority. And I think the question underlies how substance use disorder treatment is funded here in Oregon, and the priority or lack thereof that it has against other priorities, including mental health. So as my boss, Director Allen, unrelated, was talking about, there's several different funding streams that fund substance use disorder, and we help ensure through general funds that people who don't have coverage or are uninsured have access to substance use disorder treatment regardless of that. There is a service element that funds that. In part, it's also funded through federal block grant monies. The current substance use disorder waiver that we have with CMS is to help leverage additional federal funds where we've had to use general funds in the past so that our dollars go further. In terms of priorities, we set those general funds aside specifically for substance use disorder treatment, and the counties are obligated to spend it in that regard. And of course, as you also know, we have too little substance use disorder treatment here in the state, so sometimes the funds are available, but the actual services aren't, and that's related to a lack of programs, lack of bed space, lack of workforce. And so I think one of the bigger challenges that we have in a state that has one of the highest rates of addiction in the country is to ensure that we have all of the pieces of the puzzle so that we can fully leverage the funds we have and we can get people the treatment they need when they need it, where they need it.
I could just quickly add one thing that I'm related to that I meant to mention on the $3.2 billion slide. The first time I used that slide, I think was here, and I think I said something to the effect of, at that stage, I really had no idea whether that was too much money or not enough money or anything like that. Today, I would refine that a little bit, and I would say that that we need to improve accountability and specificity of services that get delivered for those resources. And to Steve's point about substance use disorder treatment, we need more of just about everything in the behavioral health system. So it's really a kind of a both and. There's a lot of money in the system. We need to do a better job of accounting for how we spend that money and getting results for it, but we also need more of just about everything. Steve.
Yep.
Okay.
Thank you.
Say about every program in state government. Yeah. Representative Hayden.
Thank you. Very quickly. So,
Jump on that comment I just made.
So to kind of assimilate those three things you just talked about, there's a lot of money. We don't know where it goes. How do you get to we need more?
Not exactly what I said. Not exactly what I said.
It's not accounted for.
We need to do a better job of having the system be transparent and accountable. I think the money is generally being well spent. I think it's hard for us to articulate on a county by county or CCO by CCO basis always in detail exactly the results that we're getting for those resources. But the fact of the matter is they're buying valuable services that people need, and people continue to have a difficult time accessing services, not because the money is sitting there unused or used on other things, but because we need more resource to be able to provide more service. The need is that great and has grown dramatically over the last period of years.
Maybe just to continue this conversation, because I think it's important. When I look at the slide that we showed just a bit ago, where we are spending $3.2 billion on behavioral health care, and if you look at the trajectory of the graph, it's greatly increased over the last couple of sessions, so thank you for that. So why isn't the system working better as a whole? And so let me just take a shot at that from my perspective. If you think about a car, there's a lot of parts to that vehicle, and all or most, maybe except the cup holders, are necessary for its smooth operation, right? So in a system where we have invested a lot of money, that funding is necessary to achieve the results we want, but in many cases not sufficient. And I'll talk a little bit about a subgroup of the population. If we think about behavioral health care along a continuum from fairly mild, an adjustment disorder, a transition that people are working to cope with, versus a severe, persistent, complex behavioral health condition on the other end of the continuum, I think where we see Oregon challenged, like other states, is that the people who have the most severe, chronic, complex conditions, we're really struggling with. They are struggling with the services that we have provided. So if you think, going back to the car, we wonder why we're not doing better. Well, maybe in some cases we start out with 2 wheels. Now we have 3, and we're wondering why we're not moving down the road. We need that 4th wheel. Sometimes it's an additional investment. Sometimes we have all 4 wheels, but they're parked in different places. The system's fragmented and they don't work very well together. We need all 4 wheels in the same place at the same time. We also need a steering wheel. We may need a clutch and a stick shift because we're just stuck in first gear and we can't figure out how to move into the second gear. So there's lots of different parts to this, and these investments we've made are critically important, and we may need more. In fact, it's likely we may need more, but as importantly, we need the system to work better across all of its parts so that we have what in essence is a car that moves nimbly and quickly enough down the road to provide those services for the people that need them. The first slide that you're looking at now begins to give a nod towards those complex populations. And so in the simple case that I described, it may simply be a conversation, a series of sessions between the person in need and the person providing the services. All are under one roof, a single provider, a single healthcare system. That is as easy as possible. And the example you see here, someone who is probably multi-systems involved. So it may include a healthcare system. It may also include the courts, corrections, social services, a child welfare system, et cetera, et cetera. And the more of these agencies and systems that are interacted, the more difficult it is to work in concert, like the car moving down the road. The slide that you're looking at now gives a nod to some of the most significant challenges that we're working with now. One is that Director Rebecca Gibson-King just talked about today in the child welfare system. Well, if we think about complex systems, we have parents, I've been told, in the neighborhood of about 60–70% whose children are in child welfare system who have addictions, and we're not treating those addictions very well. To gain success there, we have to work across both the child welfare system and the adult system, the behavioral health systems. Many of those adults who have addictions also have a mental illness. They may also have physical health challenges. If we do not address those and effectively, we're not going to gain much ground on the child welfare system because we have to work across all of those systems. Same thing with aid and assist. We think we have a very significant problem of untreated methamphetamines, and yet we are mostly treating the aid and assist as either a criminal justice challenge or a mental health challenge. We have to have all four wheels working on the car to be able to make progress in these areas, and we have to work across multiple systems. Where I think we need to go here in Oregon is to have a system where services are simple to access, that those services, when you receive them, are responsive to who you are as an individual, your race, your age, your gender, your location, and meet the comprehensive needs that you have. If we address 3 out of the 4 things that you need, and we don't help you address the 4th, all of the resources that we pour into the first 3 may not be very effective. In other words, we're not gaining the maximum ground out of the resources we already have because we're missing some critical pieces. And fourth, and the third piece is meaningful. What are we driving towards? How are we actually improving people's lives? And here I think there's strong congruence with a triple aim, that if we do the first 2 things right, that we help facilitate simple access to services that people need, that those services are actually responsive to those needs in addressing who you are as an individual and allowing for the comprehensive needs to be met, that we can improve people's health care, we can improve people's lives and the communities in the process. Let's move past that slide, given our time. So the circle on the far left, the system slide, is the system as we have it today. If we look at these 3 words, simple, responsive, and meaningful, as priority parameters that we're driving towards, and we set in place a system that continually looks at those things, that incentivizes change to make the system as a whole more simple, responsive, and meaningful. And if we begin to address each of the challenges, and I'm sure you as legislators see this as whack-a-bot, what's the current problem we're trying to solve today, and what's the price tag for trying to solve it, and yet how are all of these solutions somehow giving us a system that works better as a whole? If we use these 3 priority principles, I think we get to a system in 5 and 10 years that works better as a whole, because if we solve this problem here, perhaps in the child welfare system, if we solve this problem over here related to aid and assist and all the others that we're currently faced with, and each time we do that, we drive towards simplicity of access, more responsive services, and more meaningful change, I think we begin to bring the system closer and closer to better as a whole, to be more responsive, simple to access, and driving towards meaningful results. And I think we can do that with accountability in our contracts with the CCOs, with the CFAAs, the county financial assistance agreements, wherever we have the opportunity in rules and with legislation. I think as legislators, if you ask these 3 questions every time a piece of legislation is in front of you related to behavioral health care, does this help improve simplicity of access to services? Does this proposal in front of us help those services be more responsive to people so they actually improve people's lives? Are they actually improving people's lives? Then you have a good piece of legislation that's worthwhile investing in. If they're not, then I think it's cause to send it back and say, well, once you can demonstrate to us that it does improve simplicity of access, more responsive services, and drives towards meaningful change in people's lives and communities, then bring it back.
You drew a question. Senator Beyer.
Steve, it strikes me you said we need a system. Seems to me like this is something that really is community-based, so you really need 36 systems or maybe some number less than that. But does that speak to, and do we require now a community mental health plan or something like that that speaks to how each one is put together? And I guess in the second part of that, it seems like that ought to be related to the CCO plan to serve the area.
Yes, thank you, Co-Chairs Nose and Beyer. Yes, we used to ask for each community to provide a biennial improvement plan, and we have paused that planning prior to my arrival here and are looking at reconstituting that because it provided a lens that isn't currently captured in the CCO requirements to have local plans. So we're taking a look at how that is. But going back to your question about, is it multiple systems or is it single systems, and I think both are true. I think as a state, we need to have a framework to have the systems interplay as a whole because people migrate from one place to another, and people need to have an overall approach to healthcare that actually improves people's lives, while at the same time allowing for local and regional differences that are meaningful. So allow that local development to occur when that actually improves those three things that I just talked about, but then have a framework as a whole as a state so that you as legislators and we as the Oregon Health Authority kind of understand where we're driving towards.
And if I could just add quickly, the CCO 2.0 contracts similarly require each CCO to have a memorandum of understanding with its local community mental health program. And then we've increased the drive for CCOs to work with local public health authorities, hospitals, CMHPs, and others around the local health improvement plans, so that everyone is really trying to create the same agenda for health, including behavioral health in a region.
It strikes me, I'm thinking back to John Kitzhaber's original idea of the regional thing was that the CCO concept was to be less an insurance company and more a collaboration of the community to develop a community plan. And we seemed somewhat to have moved away from that a little bit through the contracting process. I'm not sure when I look at some of them that you have as a sense of it's a community plan as much as it is an agency or CCO plan that maybe had input from other partners, and the tie-in with the county mental health program, which the 35 CMHPs seems to me like that's the logical, consistent entry point. It may be different in each community, but it all seems to be tied to the county in some way.
Yeah. Co-Chair Knowles, Co-Chair Byer, I think I disagree with the premise of your question. I think, in fact, in CCO 2.0, what we've tried to do is improve that community connectedness across those different services. Really create a platform for collaboration. In the 1.0 contracts, the requirements for the various systems to talk to each other were actually relatively weak, and were relatively dependent on the success of a local community to be able to foster that conversation. Some were incredibly good at it, and others not so good at it. And so what we tried to do was take advantage of the strengths that we knew out there and sort of build those kinds of habits and steps into the process as a baseline requirement for everyone. And so in your region, for instance, there's now a local structure that is a community advisory process that ties both CCOs together, so that they're again working kind of off the same page in terms of community priorities. I think we're actually moving more aggressively in the direction of that community collaboration.
Good. Moving to workforce, and just to clarify, the workforce that I'm describing here is less about agency or state employees and more about the broad workforce that's needed to deliver behavioral health services, and whether that's psychiatrists, addiction medicine, MDs, whether it's traditional health workers, peer support workers, the full continuum of workforce. And here in Oregon, we have studied behavioral health workforce recently and in some depth, and so we're now in a very good position to better understand what we need and where we need to go. And so just pointing ahead to House Bill 4031, where we will be moving ahead to develop a blueprint for what do we got, what do we need, how do we get there from here. It's also important to note that we are working in an environment, an incredibly tight, historically tight labor market. So it's hard to get any workforce to work anywhere. And we cannot improve either access or quality of our behavioral health services without a much stronger workforce. And we have not only problems with recruitment, But we have very serious problems with retention. So someone who was willing to step into our workforce, who understood that they're never going to get rich doing this work, but they wanted to do something meaningful, too often those individuals are leaving the workforce for reasons that are understandable to them, but are very unfortunate for the quality and access of services that we have. So it's not just about getting more people in the field, it's about keeping the people that we have in the field. Also, just a note to Senate Bill 1553, which is part of it, looks at co-occurring disorders. Right now, we have a workforce that doesn't understand enough, and we don't have structures and reimbursements structured so that people who have both the mental illness and the substance use disorder aren't treated in a comprehensive way, something that we know from decades of research works effectively. I want to point out that in addition to the two legislative committees, that the Governor's Behavioral Health Advisory Council is also taking a look at the system as a whole, including workforce. We are taking this on along two different pathways or two different buckets. On the right, I'm just going to call this behavioral health stuff. This would be the technical term for the things where the governor may choose to invest in. That includes, we know that housing and supports, especially for individuals with the most complicated conditions, are a real challenge. The services and programs, and then workforce with work going on both in the Senate and the House on workforce, and the Governor's Council working on workforce. We understand that it'll be very important to take a look at how to coordinate those efforts. I think that each of those bodies can work in concert with each other. There's plenty of work to do. So coordinating those efforts will be critical over the next year. On the left-hand side, so the right-hand side is in partly around access. We do need more stuff in the system because we lack certain components to be able to do the work effectively. On the left-hand side is about getting the stuff that we're going to get through this council and the stuff we already have to work more effectively together. So having the data and the outcomes is critically important. If you don't have that kind of information, it's hard to tell whether the investments that you're making are doing any good. We also know that in addition to purchasing the stuff, if you will, that how you fund things can be critically important. And I think the most obvious example of that is value-based investments or pay for performance. How we use funding can drive effectiveness across the systems. And then accountability, so that we have more visibility and accountability in the work that we do, so that we know what we're getting, we know what we're buying, and what we're buying is improving people's lives. The current pressures in the system, I think, are public and are obvious, but I just want to give a nod to those. At the Oregon State Hospital, we are really struggling with capacity right now, and the story over the last number of years has been the rapidly growing aid and assist population, more than doubling over the last 5 years, and not abating. And there's more we need to know about what's driving that, but it is increasingly pressuring the capacity. When I was here with the Council of State Governments project, I remember sitting down with hospital staff, and they were challenged by the increase of the aid and assist daily population up to 200, 210. They were hoping it would cap at 220. Now we're looking at 300. At the same time, the guilty except for insanity population, after a long period of stability, has suddenly had an upturn, and the key concern there is length of stay. Capacity in a residential or hospital setting is not just beds. It's not just beds. It's beds plus length of stay. And for the guilty except for insanity population, the length of stay is about 2.5 years. For civil commits, it's about 120 days. For the aid and assist, it's about 80 days. So 11 times the length of stay that you have for the other populations. So this is critically important to understand and to manage those. As part of that, we've had a decrease in the number of beds that have been available for mental health residential. We are taking a fresh look at that as we speak to see whether some of that capacity can be rejuvenated. We also need strong community services. Ultimately, any of the residential hospital settings are temporary in nature. The solution, the answers, the long-term treatment strategies need to be based in the community. We need to invest more there and to strengthen the services that are accessible in the community. So the vision for the behavioral health system moving forward is a meaningful, dignified life is attainable for all people of Oregon who struggle with mental illness or substance use disorder, regardless of who they are, who they love, and where they're from. So happy to take additional questions.
Curiosity.
Go ahead, Senator Byer. I might have a question too. You first.
Steve, the lengths of stay, you said it's increasing. Is that a function of the illness or the design of the system that we have now and capacity issues?
Co-chairs Noes and Byer, excellent question, and we think it's a combination of several things. So one of those is the acuity or severity and complexity of the conditions that are currently being treated. Those appear to be going upwards, and we think that's in part due to a combination of both mental illness and severe substance use disorder as being a part of it, behavioral challenges. So the length of time it takes, the dosages, if you will, for treating people with those conditions is just longer by its nature. But a secondary and equally important consideration is the time it takes to find an appropriate placement for people as they're exiting care in one of those placements. And we're hearing again and again, not only from the state hospital, but from residential and other hospital providers, that it's increasingly difficult to find appropriate placements for people in community settings. And that increases the length of stay. So I think as of last week, we had about 70 individuals at the Oregon State Hospital who no longer needed hospital level of care and for whom we were searching for placements in the community. The sooner we can find placements for those individuals will increase the flow through the hospital and improve overall capacity even with the same bed count.
If I could just quickly add, I think you said something to the effect of lengths of stay are increasing. That's generally not true. They vary, and we're getting more people in the hospital with longer lengths of stay through the GEI population. But those lengths of stays themselves are changing a little bit, but not dramatically. It's the patient mix that creates the problem.
Slightly different.
You have a question too?
And then I'll be done, Mr. Chair.
Don't hold yourself to that.
You mentioned that a lot of the issues that we're seeing in mental health, the increases in problems, is related to meth addiction as well as homelessness. I've sort of wondered about that. I suspect that there are a number of people who are homeless because of mental health issues. And on the other side of that, I think there's a number of people who, to try and treat their homelessness, are going into addiction, becoming addicted, or developing mental health problems. I know you're going to do some research on that, you mentioned before, but do you have a sense about that? I suspect the thing that I hear the most about in the community is people are very upset about homelessness, but I think that kind of feeds into the other problem. They're very connected.
Co-Chair Nelson. Yeah, very astute question, and it's a complicated environment, but one piece I might encourage this committee to keep in mind is that two things. Elsewhere in the country, that in places that don't have the same level of housing challenges that Oregon have, if you have a mental illness and addiction, that cliff, if you will, between losing your housing and being able to regain it is much different than it is here in Oregon. Once you lose your housing in Oregon, I mean, there are professional people who can't keep a job because they can't keep housing, and folks in even rural Oregon providers are struggling to find housing for employees that they're trying to bring on. So you don't have to have a mental illness or addiction to have problems with homelessness or with not finding housing here in Oregon. If you do have those things, once you lose it, it's incredibly hard to gain it back. And that's in part because of the mental illness and addiction. And then once you don't have housing and you have a mental illness and addiction, it's extremely difficult to provide good care for those individuals. So it's very hard to get them out of a vicious cycle in which they've lost their housing and they can't get it back because of those addictions and our inability to provide effective services with a lack of stability in placement.
One quick data point on that, of the people in the hospital on an aid and assist order, 70% were homeless at the time of their arrest.
Wow.
It's kind of on a side issue to all this, with all the people that have been homeless for so long and had really long time, chronic mental health issues. I would imagine their medical issues have gotten more extreme and more expensive too. How does that figure out? I mean, do you have like a trajectory of that, or how much more additional costs that causes?
Yeah, co-chairs, Representative Scott, and that's exactly right. Uncontrolled diabetes is a huge problem for people with mental illness. One of the biggest interventions we provide at the state hospital in Salem when people come to us is dental work. People come in with years and years of deferred dental work, and so we've got a large dental clinic as part of the hospital, and so part of the reason that care is so expensive at the state hospital is because of that interrelationship of medical complexity with mental illness.
Steve Allen.
You said that one of your challenges at the state hospital, and I believe it's been a challenge that the Unity Hospital has identified in my community, is that there's not enough place, sort of like the step down for mental health. Like you're not quite ready to be fully in community, but you don't need a hospital level of care. What would you have legislators do to try to alleviate that situation?
Co-chairs, we just happen to have a package of investments available
All right.
for you to
I feel like I'm in those
consider.
meetings sometimes. Am I not? Okay.
By no means is that a comprehensive look. What you would expect to see in the 21 session after the governor's task force finishes their work is a comprehensive budget ask around the kinds of resources that we need to be able to build community capacity. But you do have some investments before you to be able to increase the availability of community-based restoration services, invest in more of those kinds of facilities, from secure residential treatment facilities to residential treatment homes and the rest, to be able, and then an investment at the state hospital for capacity as well. The idea being to provide some of the most critical needs right now, but what you'll have this month is a step toward a more comprehensive lift later.
Representative Hayden?
Yes, please. Thank you, Co-Chair. So I have a quick question, and I'll try not to misquote you here on anything. One of my concerns has continually been, and has, kind of experience with the dental part of this aspect going back many years, is that the fee-for-service lacks the network or the adequacy to get access to any type of care, mental health or whatever, except for hospital emergency type care. Do we have a feel for people that end up in the state hospital percentage-wise? I know the fee-for-service population is lower. Basically on Medicaid, we have 1 million people, and you got maybe 10%, maybe 15%, depending on when you look at that. But my thesis is that the fee-for-service, because of the lack of adequacy, might have a higher percentage of people falling through or getting into the system. Do we look at it from that angle at all?
That's an interesting question, and I suspect we don't, but I would want to go back and double check. What you're asking is, if people end up at the hospital prior to their being in the hospital, were they in the fee-for-service system, or were they affiliated with the CCO?
Oh,
at a higher level, yes. With
the
the thought being, if CCOs are working better for mental health and giving, wraparound services, we should be able to determine that from the amount of admissions into a state hospital level.
Yeah, the thing that you would want to temper that with is their homelessness would likely render them not being seen by either system.
Yeah.
Would be one of the things I'd want to think about in that same context.
Well, it kind of goes to the question of those that are least able to,
Right.
get themselves to a place, to a caseworker, to a CCO to get identified probably have more ability and less likelihood, which even bolsters my argument that the fee-for-service population really needs that adequacy, that network.
Yes, potentially. Another way to think about it is mostly even people who are homeless, if they're on the Oregon Health Plan and they're enrolled, not being enrolled, I think, would be a bigger issue. But if they're enrolled, generally should be in a CCO. And so then it really gets to what do various CCOs do to reach out and coordinate care to those vulnerable populations that are homeless, and are they doing what they need to do on those high priority populations that we talked about early on in one of the slides to adequately deliver services.
Co-Chairs Noss and Byer, just to add to that, it's something we've been looking at pretty carefully in the child welfare system is how individuals, children, or family end up on the fee-for-service in that trajectory. So sometimes it's a sort of a chicken and an egg. What started first? I think it's a tremendously interesting question about whether people may receive better care in a CCO versus fee-for-service. But how people ended up on fee-for-service, I think, is another element that we'd want to look at in that review.
Okay. Wow, we've had a really interesting discussion. I want to thank you for the presentation you made. I feel like either I'm starting to understand this better, or that's the most organized slideshow that sort of reveals the system that we have in our state and the challenges that we're facing with this. So thank you very much.
Only took 6 years.
No, I feel like 2. I feel like we've only been wrestling with this for about 2 years. So, with that, committee, if there's no further questions, we are adjourned.
I meant you better understand.